Hello, hello. My name is Jones, and today we are going to look at abortion. So, in this lesson, we are going to look at different types of abortions and discuss their management. Abortion is one of the leading causes of maternal mortality worldwide, and in Zambia, 6 per 1,000 women die of unsafe abortion, and 70% of abortion end up in a complication due to unsafe practices. The general objective of this lesson is that the student should be able to apply the knowledge and the skill in the management of a patient with an abortion. Then the specific objective of this lesson is that the student should be able to define the word abortion, should be able to state the causes of abortion, should be able to explain the different types or classifications of abortions and their management, should be able to apply the knowledge and the skill in the management of different types of abortion. By definition, abortion is the termination of pregnancy by the removal or expulsion of a fetus from the uterus before viability. And when you're talking of viability here, that is before 28th week of gestation from the Zambian perspective. Abortion can also be defined as an interruption or termination of pregnancy before the 28th week of gestation. So in my geographical area, I'm taking a 28th week of gestation, looking at the kind of technology that we have to support life within this period. So it's termination or interruption in the pregnancy that may happen before the 28th week of gestation. Let us now look at some of the causes of abortion. So the causes of abortion can be divided into maternal and fetal causes. So let us first start discussing some of the maternal causes of abortion. So some causes under maternal, we can talk of maternal age, we can talk of maternal infection, we can talk of structural abnormalities of the genital tract. We can also, among maternal causes, we can also attribute maternal diseases to cause of abortion. We can also talk of endocrine abnormalities. We can also attribute incompetent cervix to be one of the maternal causes. We can look at stress anxiety as one of the maternal causes. We can also look at environmental or social factors to be contributing to maternal causes. We can look at noxious agents as one of the maternal causes. We can also look at nutritional deficiency as one of the maternal causes. And lastly, not the least, under maternal causes, we can also look at abdominal surgery. So under maternal causes, one of the attributing factors is maternal age. Women who are 30 years and above are at high risk because of the degenerations that happen of the ovaries that leads to low levels of progesterone, which maintains the pregnancy. Low levels of progesterone lead to abortion. Then on maternal infections, bacteria, viruses, and parasites may invade the placenta and affect the metabolism of the placenta, leading to early degeneration. So some of the maternal infections that we can talk of that may lead to abortion include toxoplasmosis, cytomegalovirus, syphilis, chlamydia, malaria being one of the common causes of abortion from my geographical position. Then the other maternal cause that we can also look at as a contributing factor to maternal to abortion is structural abnormality of the genital tract. So on structural abnormalities of the genital tract, we can look at retrovasion of the uterus, biconjugate uterus, uniconjugate uterus, and fibroids as some of the factors that may hinder the growth of the fetus. Then the other maternal cause is maternal diseases. So maternal diseases may include conditions such as anemia, hypertension, renal disease, cardiac diseases. These may lead to placental insufficiency and subsequent abortion. Poor placental perfusion make it weaker, and eventually it starts to detach from the mother's womb, leading to abortion. Then the other maternal cause of abortion is endocrine abnormalities. Poor development of the corpus luteum, inadequate secretory endothelium, and low serum progesterone levels may lead to failure of the pregnancy to be maintained. So under endocrine abnormalities, we are just looking necessarily at poor development of the corpus luteum or inadequate secretory endothelium and low serum progesterone levels. Under maternal causes, the other contributing factors to abortion is incompetent cervix. This may come in due to inadequate cervical collagen fibers, which makes the cervical os weak, leading to failure of the cervix to contain the weight of the growing fetus. Conditions like previous induced abortions and congenital cervical defects are the main causes of cervical incompetence. The other maternal cause of abortion is stress and anxiety. This is necessarily due to the effects of stress hormones, which cause vasoconstriction, leading to reduced blood supply to the fetus. Then the other maternal cause of abortion is environmental or social factors. So when you look at nutrients like caffeine from coffee, nicotine from cigarette smoke, this causes vasoconstriction, leading to poor placental and fetal perfusion, causing an abortion. So someone who has got a social life of of smoking or taking caffeine, or within their environment there are certain pollutants, it may lead to an abortion. Someone with a lifestyle or social lifestyle of alcohol consumption, this may lead to poor maternal nutrition and subsequent may lead to abortion. And necessarily within the environment, there can be noxious agent, exposure to chemicals such as cytotoxic drugs, organic solvents such as lead and radiation from the environment may lead to abortion. Away from environmental and social factors are nutritional deficiencies such as malnutrition and lack of folic acid that may lead to abortion. Then abdominal surgery. This is due to trauma of surgery that may induce an abortion, e.g., for instance, during myomectomy or laparotomy, it may lead to abortion. Okay, so now with maternal causes of abortion discussed, let us look at some few fetal causes of abortion. So some fetal causes of abortion include the chromosomal anomalies, multiple pregnancy, or fetal infections. All right, so those are some of the fetal causes. So when we look at chromosomal anomalies, the malformation and abnormalities of conceptus and faulty implantation leads to an abortion. Then the other fetal cause to do with maternal multiple pregnancy, these tend to increase pressure within the uterus, and this increased tendency may lead to spontaneous abortion, cause of pressure within the uterus. Then fetal infections like rubella may lead to abortion. Okay, so we have discussed some causes of abortion, which is under maternal and fetal causes. Let us now look at types or classifications of abortion. Basically, there are two major classifications of abortion. That is spontaneous and induced abortion. So when you're talking about major classification of abortion, it can either be spontaneous abortion or induced abortion. Okay, so when someone has spontaneous abortion, it may go further and end up as threatened abortion. If someone has a threatened abortion, it may end up that the pregnancy may reach term. If it may reach term, and here it means we're going to have a viable fetus or viable neonate because it has reached to term. But otherwise, someone with threatened abortion, if it does not reach to term to deliver a viable baby, then it will be a missed abortion. So if threatened abortion ends up as missed abortion, it may form a blood mole or a cutaneous mole. So from spontaneous abortion, it may end as threatened abortion. Threatened abortion may end to term for a viable neonate to be born, or it may be mixed abortion, of which it will end as a blood mole or a cutaneous mole. From threatened abortion, it may also end up as hydatidiform mole. Okay, from mixed abortion, it ends up as blood mole or cutaneous mole. Okay, or threatened abortion may end up as hydatidiform mole. threatened abortion may also end up as inevitable abortion. And when it ends up as inevitable abortion, it can proceed to complete abortion. Okay, so when it proceeds to complete abortion, it may end up as habitual abortion, where abortion becomes more of a habit. Otherwise, from threatened abortion, it may end up to inevitable abortion, and then from inevitable abortion, it may, instead of being complete abortion, it may end up as incomplete abortion. So that is our discussion there on spontaneous abortion. From complete abortion, it may end up as habitual, and then from inevitable abortion, it may end up as incomplete abortion. It is also important to know that inevitable abortion may end up as a septic abortion. Incomplete abortion, may end up as a septic abortion if it ends up as incomplete. Because of retained product of conception, they may harbor some infection. But otherwise, if it is complete, less likely to end up as septic abortion, but more likely to become a habitual abortion. So retained product of conception tend to be source of infection. That's why incomplete abortion ends up to be septic abortion. All right, so we have discussed that basically there are two types or two classifications of abortion, which is spontaneous abortion and induced abortion. So to do with induced abortion can either be therapeutic abortion, that is a termination of a pregnancy due to medical reasons, or it can be criminal abortion. So incomplete abortion, therapeutic abortion, or criminal abortion may end up being a septic abortion. So the second classification of abortion is induced, which may either be therapeutic, that is due to medical reasons, or criminal. And all these may end up being septic. And from the inevitable abortion, incomplete abortion becoming septic. So it's important to know under these classification of abortion, what resulting type of abortion may come, what results may come after each. So we have discussed the two classification of abortion as being spontaneous or induced. So from induced, it just ends up in either two, either being an induction of abortion due to therapeutic reason or induction of abortion due to criminal. And these may end up to be septic. But when you look at spontaneous abortion, it may either just end up as threatened and eventually baby going to term. But if it does not end up as threatened, it may end up as a missed abortion. Then you have a blood moor or a Kenya small. Or from threatened abortion, it may end up forming an hydatidiform. Or it may move from threatened abortion to inevitable abortion. ending up to be either complete or incomplete. Then from complete it becomes habitual. Then from incomplete it can end up as spontaneous. So now let us add more details to these types of abortions that we have just discussed. So our first discussion on these types of abortion is that to do with spontaneous abortion. Spontaneous abortion is the termination of pregnancy that occurs without external interference. So for spontaneous, it's happening spontaneously. So there is no external interference. Okay, so spontaneous abortion is divided into threatened, missed, inevitable, complete, incomplete, habitual, or then the last one being ending up as septic abortion under spontaneous. Then we can also discuss threatened abortion. So threatened abortion is a spontaneous type of abortion in which a pregnant woman presents with a slight bleeding through an undilated cervix. On clinical features, blood loss is scant, with or without lower abdominal pain and backache. But the cervix is closed and uterus is soft and non-tender. So these are some of the clinical features of threatened abortion. There is spotty bleeding, or there is some scanty vaginal bleeding, with or without lower abdominal pain and backache. The cervix is closed, uterus is soft and non-tender. On the management of a threatened abortion, our aim is to prevent abortion from becoming inevitable. Our aim in management of threatened abortion is to prevent abortion to become inevitable. Therefore, some investigations that can be done include obtaining history and doing physical examination. Other investigations that confirm that the fetus is still viable. Ultrasounds may help to determine the viability. The treatment for threatened abortion include bed rest, medication, and some observations that can be done, issue of diet, and also matter of hygiene can be addressed in the management of a threatened abortion. So bed rest is the most important form of treatment so that the woman has total physical and mental rest. The patient should remain in bed for 5 to 7 days or for as long as blood is bright red. Bed rest increases blood flow to the placenta and reduces pain. It is also important to give psychological care to the mother due to lifestyle modification that may happen because of the bed rest requisite in managing threatened abortion. On medication, it is important to promote sleep by giving mild sedatives like diazepam to enable patient rest in bed. If uterine contraction becomes stronger, analgesics such as pethidine, 100 milligram intramuscularly, or morphine may be given. It is important to avoid non-steroidal anti-inflammatory drugs, as they may worsen the bleeding in this situation. So opioids, analgesia become drug of choice in the management of pain. Then Ventolin tab 4 milligram 3 times a day is given necessarily to help relax the uterine muscles. Ventolin, also butamol, has also been given to help delay labor, so it also helps in the relaxation of muscles in threatened abortion. So it's important to note that. On observation, pads should be saved in order to help assess the amount of blood loss. Sewed linen report should be done for any bleeding, like clots and any abnormal tissue through the birth canal that may be observed to be coming out. You can observe for pain. Vital signs are done and recorded, and it's important that in threatened abortion, it's important to avoid or not to do vaginal examination at all. This is because it may induce uterine contraction and induce abortion. On diet, in the management of threatened abortion, that it should be light and non-stimulating. This is to prevent uterine contraction. So the patient should be encouraged to have light diet. On matters of hygiene, it's important to encourage a change of sanitary pads to prevent infection, and also importance of doing vulvar swabbing to avoid infection. All right, a point to note here is that urinalysis should be done to exclude urinary tract infections like cystitis, which stimulates these symptoms. And you can also rule out ruptured ectopic pregnancy. You also rule out dysplasia, rule out carcinoma or polyps, as they may also cause bleeding in pregnancy. From threatened abortion, let us now look at a missed abortion. So this occurs when the fetus, when I'm talking about missed abortion, this necessarily occurs, when you're talking about missed abortion, this necessarily occurs when the fetus dies and is retained in utero together with the placenta and the membranes. So missed abortion is when the fetus dies and is retained in utero together with the placenta and the membranes. The clinical feature of missed abortion is that there is no pain, uterus does not grow, breast is soft. There are signs of pregnancy. Signs of pregnancy may start to disappear. The brownish vaginal discharge may be seen, and fetal movements. There will be absence of fetal movements or movements within the lower abdomen. Management of missed abortion includes uterine evacuation if pregnancy is less than 12 weeks. So for pregnancy less than 12 weeks, we do a uterine evacuation. So oxytocin infusion or vaginal insertion of oxytocin such as misoprostol to expel the product of conception can be done. If in a clinic, you can refer cases of missed abortion to hospital for surgical evacuation and the checking of uterus. Here may be necessary for any abnormal signs that may lead to complications. So for pregnancy, in missed abortion, for pregnancy, which is less than 12 weeks, you can do a uterine evacuation. Some cocktail of drugs that can be used include misoprostol, which helps in expelling a product of conception. And if at a clinic, it's important to refer to the hospital for other observations to do with uterus abnormalities and the likes. Then the other type of abortion that we can talk about is inevitable abortion. An abortion is inevitable when the pregnancy can no longer continue. It may complete or incomplete. Some clinical features of inevitable abortion includes progressive dilatation of the cervix, bleeding becoming heavier and severe. There can be abdominal pains, which may become more severe with a stronger contraction. Okay, abdominal pains, they are colic in nature and they are situated within the suprapubic area. Mother may be distressed due to blood loss, pain, and the sense of loss. So these are some of the clinical features in inevitable abortion. Management of inevitable abortion: you have to admit the patient, explain to the patient what is necessarily happening, and do vital signs to rule out shock. You can administer oxytocin to control the bleeding. Then surgical curettage or MVA may be indicated to remove retained product of conception. Okay, then you can check the hemoglobin after 24 hours because of blood loss that may tend to affect or to complicate into anemia. Then the other type of abortion that we can talk about is incomplete abortion. Incomplete abortion is one in which part of the product of conception, that is the placenta and membranes, are retained. So in incomplete abortion, okay, we have a product of conception which can either be placenta or membranes being retained. The clinical features of incomplete abortion includes a backache and abdominal pains, which may be quite severe. There can be perivaginal bleeding, and if bleeding is profuse, there can also be signs of shock. Signs of shock due to blood loss, signs of shock due to septicemia, such things can be seen in incomplete abortion. On management of incomplete abortion, patient is admitted and resuscitated. And 1 liter of normal saline is commenced in addition with syntocinon or oxytocin 10 international units. This is to initiate contraction so that the products are expelled. You can monitor drops of oxytocin at 10 drops per minute and then observe. After an hour, you can increase to 20 drops till you increase to 60 drops per minute, okay, with increasing drops hourly. You can collect blood for grouping and cross match. You can do an evacuation of the uterus by MVA or dilatation and curettage. You can give the patient strong analgesia, such as pethidine, during the procedure, as use of non-steroidal inflammatory drugs may worsen the bleeding. So opioid analgesia like pethidine can be given. Antibiotics can be given only if the patient is febrile. If patient is in shock, you can start a plasma expander drip like a normal saline after taking blood for grouping and close match. You can also do a sterile vaginal examination and remove any placental tissue distending the cervix with a sponge holding forceps. You can give oxytocin 10 international unit intramuscularly. Once these steps have been taken, the condition usually improves and the patient can safely be transferred to the hospital. Okay, so we have necessarily looked at incomplete abortion. Now, let us appreciate another type of abortion, which is a complete abortion. The term complete abortion signifies that all products of conception have been expelled. In short, the opposite of incomplete abortion is complete abortion. So the clinical features of complete abortion include the uterus becoming smaller on palpation. On vaginal examination, cervix is closed. Patient usually notices expulsion of the tissue or even fetus and the placenta. The abdominal pains subsides in complete abortion. Then bleeding may stop or slows down considerably. It's important to note that you can treat any abortion as incomplete until an examination is done. In management of complete abortion, we can encourage patients to rest in bed, and if possible, you can sedate the patient with diazepam. You can evacuate the uterus as soon as possible to ensure there is completeness or there's completeness in the evacuation of product of conception. Because of blood loss that happens, which leads to anemia, you can check the hemoglobin levels after 24 hours and do an MVA or curettage only needed if bleeding persists. So MVA or curettage can be done if bleeding persists. All right, so from complete abortion, let us now discuss habitual abortion. A habitual abortion is a situation where there has been 3 or more consecutive abortions, mainly due to congenital malformation of the uterus and an incompetent cervix. It might be interspaced with the normal deliveries. Management of habitual abortion, you can admit the patient. Investigations necessarily will be done to find out the cause of this abortion. If the cervical os is incompetent, Shilotka suture can be inserted at the appropriate time in preserving the pregnancy. Then perivaginal bleeding can also be observed for someone with habitual abortion. Then pain may be relieved by giving strong analgesics such as pethidine, and then observations and vitals can be done. Sexual intercourse is done with caution to prevent a disturbance up to the suture. That is the Shilotka suture if it is inserted, and in severe cases, sexual intercourse may be suspended temporarily in preserving the unborn baby, the unborn fetus to reach to term. Otherwise, complete bed rest is advised in preserving a pregnancy, and a high standard of hygiene can be observed to avoid infection that may precipitate an abortion. Okay, then now we can look at induced abortion, which is another classification of types of abortion, or another classification of abortion. Induced abortion is defined as termination of pregnancy that occurs due to external interference. Induced abortion can either be therapeutic or can be criminal abortion. Okay, so under induced abortion, we can discuss therapeutic abortion. Therapeutic abortion is an abortion which is performed by a trained medical doctor for medical reasons. An abortion is considered to be therapeutic when it is performed to save the life of the pregnant woman. It will be considered as therapeutic if it is performed to preserve the woman's physical or mental health. It can be considered to be therapeutic if it is performed to terminate a pregnancy that would result in a child born with a congenital disorder that would be fatal or associated with significant morbidity. So, apart from that, it can also be performed to selectively reduce the number of fetuses in lessening health risk associated with the multiple pregnancy. The other type of induced abortion is criminal abortion. Criminal abortion is the termination of pregnancy by unauthorized person, or it is an abortion that is illegally done. It is an offense and punishable by law to conduct this type of abortion. Criminal abortion can be complete or incomplete and predisposes to serious conditions such as sepsis or septic abortion. It may also lead to complications such as perforation of the uterus. It may also lead to complications such as severe hemorrhage. It may also lead to complications such as kidney failure and other complications, apart from also the other complication that is seen, which is a death. Okay, so we can also discuss septic abortion falling necessarily under criminal abortion. When you talk of septic abortion, we are necessarily looking at infection that can complicate any type of abortion. If the infection is splayed into the maternal systemic circulation, it is usually called septic abortion. Illegal or criminal abortion may be the cause of most cases of septic abortion, mostly due to retained product of conception. And the risk to the patient is not only from the sepsis or the unsterile instrument or environment in which this abortion is conducted, but also the risk may come due to associated injuries that may happen during this type of abortion. Some clinical features of septic abortion includes anemia, pyrexia, tachycardia, headache, offensive lochia, usually profuse, and uterus is bulky and very tender. Okay, now let us look at management of septic abortion. So management of septic abortion, here we are necessarily looking at the infection that may cause the septicemia. So infection of the uterus may follow any abortion, especially an incomplete or induced abortion. This is usually caused by gram-negative E. coli, but sometimes gram-positive streptococci and staphylococci can be involved. So treatment of these patients with septic abortion is an emergency, as delay may result in severe complication or death. So patients should be managed in the hospital if possible. However, treatment should be instituted as soon as the diagnosis is made. So septic abortion becomes one of those gynecological emergencies of which a delay may lead to severe complications like death. You can isolate the patient, resuscitate with intravenous fluids, give parenteral blood spectrum antibiotics. You take a cervical swab for culture and sensitivity before starting antibiotic treatment to identify the causative organism and the drugs to which those organisms are sensitive to. Blood transfusion can be given in cases of low hemoglobin levels, and most patients will have fluid deficit from blood loss during abortion or from poor fluid intake due to ill health or fever. Evacuation of the uterus should be instituted immediately resuscitation is complete, and antibiotics then should be started. Okay, so now let us now look at necessarily the nursing care that can be given to a patient after an abortion. The general nursing care that should be given to the patient following an abortion. Our goal of our nursing care in this is to prevent a shock, to relieve pain, to allay anxiety, to provide post-abortal care. So in the immediate care, the following should be done. Following post-abortal care, the woman is still at risk of bleeding and developing shock. Therefore, close observation should be made until discharge. Vital signs of temperature, pulse, and blood pressure is done to rule out shock, and you can check for other signs. Okay, shock will, for shock, the patient may have cold, clammy skin. Patient may be restless. they may have feeble pulse. So you need to check for signs of shock, like cold, clammy skin, restlessness, and a feeble pulse. Other things that can be done within the immediate care is explaining the prognosis of pain and giving prescribed pain relief drugs. You can observe the contents, consistency, and the color, and the odor, and also the amount of birth canal discharge. You can also observe for pallor, dehydration, and any possible signs of jaundice. You can note the degree of pain, which may indicate presence of a retained product of conception. You can observe woman's reaction to the loss through interaction and promote the rest by minimizing the disturbance and carrying out procedures collectively in order to allow patient to rest. If on IV fluid, you can maintain a fluid balance chart and note the intake and output to rule out hypovolemic shock and renal failure. So this is important that it is done for the patient within the immediate care. Then other things within the management of patients with abortion includes hygiene or prevention of infection, rest activity, and post-abortal counseling. Apart from post-abortal counseling, then you can give information, education, and communication. So on hygiene and prevention of infection, vulvar hygiene is paramount in post-abortion due to risk of ascending infection. Therefore, vulvar swabbing will be done frequently in acute phase, and subsequently the woman will be encouraged to take baths and change pads frequently. You can change the linen whenever sold and ensure aseptic techniques are followed during all the procedures that are done on the clients. You can use clean and sterile equipment such as speculum, forceps, and the MVA equipment. On rest and activity, due to excessive loss of fluids, because of pain due to excessive loss of fluid and the pain that the patient is in, the woman will be feeling weak and tired. Therefore, rest should be ensured until complete recovery. You can involve the partner or support person and explain the importance of rest during the recovery phase. You can introduce exercises gradually as can be tolerated. Okay, then on post-abortal counseling, the main aim of counseling is to ensure that the client is availed with family planning services to prevent repeated abortion. This should be done to all women, also to allow for recovery. Counseling should be done using profiling system, and it can be done individually or on group whilst upholding the patient's confidentiality. Patients should be referred appropriately to the next level of care if necessary, and document all the information that is necessary. You can involve the partner or support person and explain the importance of post-abortal conception. The possibility of woman conceiving almost immediately is quite high, hence the need for them to wait for about 6 months to allow for recovery. Information, education, and communication. During the IEC or information, education, and communication, you can involve the support person and comments from the known to the unknown. Hygiene and prevention of infection should be some of the things that you should educate the patient on. Educate the patient on nutrition, rest, family planning. You can also give a sexual advice and the importance of review date, early antenatal booking if at all she conceives, in preserving pregnancy. On the complications of abortion, the complications of abortion may include infertility, which is secondary to infection, and healing by fibrosis, which may block the fallopian tubes. The other complication of abortion is hemorrhage due to continued bleeding or problem with clotting factors. Anemia may also come in due to severe blood loss or disseminated intracoagulation may come in as one of the complications. As infection also ascends, it may land into the peritoneum, leading to peritonitis. That mostly is due to perforation of the uterus or infection that ascends to the peritoneum. Then septicemia may also happen. That is infection within the blood because of poor hygiene. And then shock may happen because of infection, or it may happen because of blood loss. So there you have it. Today we are looking at abortion, which is one of the leading causes of maternal mortality worldwide. We defined abortion based on our geographical location, that it is termination of pregnancy by the removal or expulsion of the fetus from the uterus before viability, and that is before 28 weeks in a pregnancy. So termination or interruption. Then some causes of abortion may be maternal, may be fetal. Then we talked about two main classifications of abortion, which is either spontaneous or induced. Induced ending into therapeutic or criminal, then septic. Then spontaneous ending up to be threatened. From threatened may end up to tame, or it may end up to be missed. It may end up as a hadad for more, or it may end up as inevitable abortion. When it ends as missed abortion, it may progress to either blood more or Kenya small. Then when it ends from threatened abortion, when it ends up is inevitable, it may either be complete or incomplete. When it ends up as complete, it may progress to be habitual abortion. And if it from inevitable abortion it goes to incomplete, then it may complicate into septic abortion. So we discussed the brief management of each and every type of abortion that we have just mentioned here. So thank you from me, and I'm saying keep studying. We have recorded a lot of lessons in obstetrics. We have recorded a lot of lessons in gynecology. So I urge you to look at all those lessons as abortion is discussed in gynecology. So from me, I'm saying thank you.